Hello, everyone. Good afternoon. Thank you all for staying up this late. My name is Ahmad Alanezi. I am from Kuwait, and I am very honored today to present to you a lecture about implant aesthetic. Just a little bit background about me. I graduated from Mohammed bin Rashid University. I did my prosthodontic training there. I am a prosthodontist in Kuwait Ministry of Health. I joined Harvard School of Dental Medicine to do implantology training there, and I'm currently a member of the Royal College of Surgeons in Prosthodontics. So today's lecture is implant in the aesthetic area. And as we all know, implants have been extremely successful, both in the biological aspect as well as the mechanical aspect. But we often encounter a lot of complication, especially when it comes to the anterior aspect. And the reason for that is because either the restorative dentist or the surgeon did not implement special consideration. And I will show you in this presentation the consideration that we need to take into account when we plan those cases, as well as show you two cases where we implemented those considerations. So one of the first important consideration that we need to take into account is the peri-implant mucosal soft tissue. This is extremely important because you ideally want to have a disease-free environment. And if you have a peri-implant that's deficient, you need to know how to create it. And if you have a peri-implant soft tissue that's present, and it's before the tooth is extracted, you need to know how to keep it. The second one, as a prosthodontist, I should always think with an end of mind. So knowing your restorative design is also extremely important. Knowing what type of material you're going to use, and whether you have enough restorative space for it or not. The third one is knowing your proper 3D position. Ideally, you should focus to be in a screw-retained fashion, but also you need to keep the biology in mind and know how much bone quality and quantity you have to begin with. And fourth is the abutment selection. Every abutment has its own indication. So some abutment are tie-based, some are custom abutment, and some are angulated. Each of these abutment will give you different indications and should be used in different cases. And fifth is the implant timing and the provisionalization timing. And as we all know, that implant, anterior immediate implant, produce a much better aesthetic result when you compare it to the healed site. And the reason for that is because we minimize the 3D shrinkage, both in the vertical and the horizontal aspect that undergoes during the healing. And the last one is the emergence profile. Ideally, your emergence profile also should be within 30 degrees, so you don't create an area where you accumulate food and then you develop perimucositis, and then periimplantitis, and possibly even have a bone loss. And I have this article that even supports from my program director, Dr. Herman Galucci, that when you use a wider healing abutment during a micro-CT analysis, they found out that it negatively impacted the peri-implant mucosal width. Let's jump to the first case of the day. The patient is a female with high smile line, and she's very concerned about her aesthetic. And as you can see, she's missing the canine, and the case is already a complex case because it has a high smile line. So let's check the restorative space. We found out that the patient has good amount of restorative space, both in the vertical and the horizontal aspect. We checked the soft tissue characterization. The patient is having good keratinized tissue, height and width. The adjacent papilla are present. The mucogingival line is away from our flap design. There is no vertical deficiency, but there is a horizontal deficiency. And in order to be aesthetically pleasing and biologic, you need to correct this deficiency, as well as restore the patient with a tooth. And the best two ways to do that is either bone augmentation or soft tissue augmentation. And to find out on which technique you're going to use, we should put this in the virtual world and first design our restorative restoration. So we acquired all the data for this patient, and we put it in the implant planning software. And then we placed our implant prosthetically driven. We even selected our prosthetic abutment before we start the surgery. And this is our provisional design. What we wanted to do extra in this case, we wanted to push digital dentistry further. We wanted to create the prefabricated restoration prior to the implant surgery. And in order to do that, which is a new approach, in order to do that, we had to integrate two different software together. One is a CAD software and another is an implant software. Any changes you make on the implant software will represent in a real time on the CAD software. Any changes you make on your CAD software, it will also be visible on the other software. In this way, you will be able to lock your implant position and make your restoration in a screw-retained fashion, and hopefully be able to deliver it in the day of the surgery. So after we locked the implant position, we created our surgical guide, we printed our restoration prior to the surgery, we cemented it over the tie base, and now let's see if we were able to be, if we're going to be successful in screwing in this provisional during the surgery. So a surgical guide was placed, and we made sure that the surgical guide is fully seated to ensure high level of accuracy. And we opted here to go with mid-crystal incision because it's the least vascular area, as well as to bring some of the buccal flap on the provisional, and we'll have a creeping of the soft tissue. And a full guided protocol was implemented in this case. Implant was selected. Implant was placed through the surgical guide. And here what we had to really pay attention to is to have a depth control. Not only a depth control, but also rotational control. If we had any changes or any inaccuracy in either the vertical axis or the rotational axis, our abutment or our screw-retained provisional will not be seating. So this is how the patient looking like on the day of the surgery, and we're extremely happy with the results so far, and we're hoping that our provisional will be screwed in. So we tried the provisional, and it's finally screwed in place without any adjustment. And that means we were extremely careful and we were extremely accurate in our planning and in our execution. This is the patient occlusal view on the day of the surgery, and this is the patient occlusal view on the virtual ward. They are extremely identical to each other without mimicking the planning phase into the day of the surgery. We wouldn't be able to put this temporary restoration. We harvest our connective tissue graft from the palate, and then we ideally made it at 20% to 30% larger to compensate for the shrinkage that usually happens. And this is the free gingival graft. We did our CTG bed preparation after that. We de-epithelized our connective tissue, our free gingival graft. We secured it in the buccal aspect of the implant, and then we placed it on the buccal aspect of the implant. Notice it is a bit more over. The contour is more puffed than it's supposed to be. This will this situation will be minimized during the healing phase, because usually the body goes under 3D shrinkage during the healing phase. Hemostasis was achieved with the Gore-Tex suture and collagen tape. And this is the patient on the day of the surgery after the suture. Notice the mesial papilla here. And notice the mesial papilla 3 weeks after. We were able to achieve a new papilla heights. We were able to achieve new gingival creeping, not because of my surgical skills, but because we created the environment for it and we trusted the biology. Final impression was taken, screw-retained restoration was made, and this is the initial situation that the patient came with, and this is how we ended up on the day of the insertion. And we take a PA and we found out that our restorations are fully seated, and we are happy with the results. We take a look at the occlusal view, and we found out that with connective tissue graft, we were able to correct the soft tissue continuity. And that's how everything is looking like. And we were able to produce to this patient an aesthetic pleasing smile, as well as biological restoration. Let's talk about another case that instead of creating a soft tissue, we had to preserve the existing amount of soft tissue. So this is the patient, came to the clinic, and he's missing tooth number 9. And after further examination and with the patient, we found out that the patient is having a diastema, there's tooth wear, and there is deep bite, there is a fracture of tooth number 9, and there is a deficient metal ceramic on tooth number 8. So after careful assessment, we found out that 8 and 9 needs to be extracted. So we told the patient we need to extract 8 and 9, and we are going to place an implant in 8 and 9, but in order to close the diastema, we need to have a laminate veneer on 7 and 10. And that's what we did, and the patient agreed to the treatment plan. But we also told him, we will not be able to restore you with a screw-retained provisional, because we wanted to protect our implant throughout throughout the process. Instead, we will create him a socket seal abutment, which is also called as a customized abutment. And the reason we want to create that is because we want to preserve the soft tissue architecture, as well as seal the socket during implant surgery for our bone grafts. So we strategically place our implants. After doing our wax-up, we strategically place our implant to be 3 to 5 millimeter deep in the apical part to ensure high insertion torque during implant surgery, to be 3 millimeter away from the buccal plate for our bone particle to be placed in, and to be 4 millimeter in depth so we can have enough supercritical attachment. And the surgical guide was fabricated to replicate the plan, and this is the day of the surgery. This is how the patient, so we did a traumatic extraction. We made sure the buccal plate is intact. We placed our surgical guide. We placed our implant in a fully guided fashion. Then we put our prosthetic abutment. We made our socket seal. We put our bone graft. Then we put back our socket seal. 3 months after, this is how the patient is looking like. We were able to preserve the soft tissue architecture, and we were able to proceed with our digital impression. Digital impression was taken, digital and screw-retained provisionals and laminate screw-retained restorations and the laminate veneers were made. And this is how they are looking like. Now before we try in, so we also made sure that our screw-retained are applying the EBC concept, which will have the emergency profile, aesthetic pleasing and biological, and will stabilize our soft tissue during the restoration period. And we had the reverse S curve will support our ABC concept. So this is the day of the insertion. We tried our restoration. We talked our restoration to the manufacturer recommendation. And we also made sure that the occlusal premature contact are eliminated, not only the protrusive aspect, but also on the latrusive aspect. Otherwise, we might jeopardize our implant. And this is the patient on the day of the insertion. We take a PA to find out that our implants are fully seated, and this is a CT after 1 year of post-op of implant placement. And this is the initial situation of the patient, and this is the final results of the patient. And we were able to achieve, with applying these concepts that we discussed earlier, a highly aesthetic smile and a highly biological also restorations. And the patient was happy, and we were happy with the results that we achieved. And we wouldn't be able to achieve this result without implementing all these 6 principles that they work in a synergy. So not each one of them are important, but they all work together. And with that, I'd like to thank you for your time and for your attention, and thank you.